Good afternoon. It's so fun to see all the energy in the room and everyone coming together. I'm Denise Reinke, and I'm a member of the board of SPAGN. By way of background, I'm a sarcoma nurse practitioner, and I have been engaged with patient advocacy through many different roles that I've had. When I was CEO of SARC, we brought patient advocacy voice into the work and research of SARC. I have worked with the groups across the United States to form coalition of advocacy groups and worked on several projects internationally, bringing the voice of the patient to the research work. So I'm really delighted to be here and to be welcoming you to our first meeting outside of Europe in the United States. So it really is my great pleasure on behalf of the board of directors. Okay. All right, I pushed all the buttons. Well, SPAGN has had a tradition of meeting in person since 2009. If somebody wants to just advance the slide. And this format of a 3-day meeting of coming together, bringing patient groups, experts, researchers, and industry together. Should have had that last word memorized. To really help us focus on research, treatment, and advocacy. So which one? The red one or this one? The arrow. Okay, perfect. Great. Thank you so much. And really focusing on research, treatment, advocacy, and how do we build capacity across our advocacy groups. We have had in-person meetings with approximately 80 to 100 participants from over 25 countries. So initially, SPAGN started out as a really small organization of 11 patient organizations coming together. Their first step was gathering together and really kind of chewing on the idea and pulling it together and figuring out, is this something that we can really do? And then by April of 2009, they formed and founded a group called SPAGN, S-P-A-E-N. But as time went on and bring us to 2025, we find ourselves now larger than nearly 70 organizations spanning every continent, and we have now moved into 2023 from SPAEN, Euronet, to SPAGN, a global network representing patient advocates from across the world. And so with that movement to being more global, as we thought about our meetings within the EU, we kept thinking we need to really move beyond that and truly be a global community and represented in our meetings as well. And so we find ourselves today in Washington, D.C. As we looked at different places we could go, we thought this is really a good place to bring this group together. It's really kind of a city that many people recognize internationally. There are many of our monuments to our presidents, whether it's to Washington or Lincoln or the Jefferson Memorial. We have our iconic Capitol building, where our legislative branch and our home of our president, our White House, our cathedral. We've got Smithsonian museums and art museums, and there are so many things within this city that makes it really quite a perfect city to bring you to gather as our first foray outside of Europe. But even more importantly, we have the opportunity to meet with people from the National Cancer Institute, which is just down the street from us, as well as some members of the FDA. And so really, beyond being such a symbolic city with much history of the United States, it also is a place for people, especially facing uncommon diseases, uncommon cancers like sarcoma, to come and meet with, and we're going to have this opportunity in the next few days, meet with people from the National Cancer Institute that care about these diseases, are looking to make progress, and are working internationally to be collaborative. We happen to be here at a particularly lovely time of the year. In Washington, this is really a special time where the cherry blossoms are in bloom. And kind of thinking back on my US history, that I had quite a few years ago. I remember that it was like in the early 1900s that the Japanese had given as a gift to the United States thousands of cherry trees. And each year they now celebrate this. And as I looked a little further into the history, I found that it didn't begin just in the early 1900s, but it was in 1885 that Eliza Skidmore, she was really a woman ahead of her time. She was a diplomat, she was a world traveler and a writer, and she had been visiting in Japan and came back to the United States and said, you know, we really could use some of those beautiful cherry trees to just fill in some of our kind of barren landscape here in Washington. And in 1885, she began to advocate for the bringing of cherry trees to the United States and to Washington, D.C. And she's raised funds and she found people to advocate for her. And finally, she found an ally in Mrs. Taft, the First Lady, President Taft's wife, along with the ambassador from Japan. And she got to see her vision actualized in 1912. So I think we can learn a little bit about perseverance. And so when we think about the global network of sarcoma patient advocacy and our mission and our vision, we recognize that our mission as a network is really to strengthen one another, to provide a common and international patient voice, to really work across borders to achieve the necessary change together with our collaborators. And it's our vision that one day sarcomas will be preventable or curable. But until then, patients, experts, and all of the stakeholders need to work together globally to drive sarcoma research, to improve early and correct diagnosis, secure timely access to interdisciplinary expert care, and then provide patient-oriented information and support. And it's really our goal to make sure that no more sarcoma patients, so to make sure that more sarcoma patients will live longer and with a better quality of life. It is on behalf of the Board of Directors of SPAGN that I welcome you here today. We have our chairs, Marcus Wartenberg and Gerard Usmerson. We have our honorary chairs, Roger Wilson, who's not able to be with us today, but Estelle Arntzner is here with us. We also have Vandana Gupta, who's here with us, Sorel Bickley, who unfortunately couldn't be here, Christina Baumgartner, Ornella Gonzalo, Bernd Casper, Gabby Ott, Brandy Felser, as well as the support of our SPAGN team under the leadership of Catherine Schuster as our executive director, and the team of Miki and Corey and Ivana. And we really welcome you all wholeheartedly to be here with us in Washington. And we really hope that at the end of this meeting, we can really operationalize our vision to turn ideas into reality, to really not just talk, but really work together to say, how do we make some of these ideas really take root? Well, as we were thinking about where to come for our first meeting outside the United States, and we had decided on Washington, D.C., we reached out to the National Cancer Institute and the Center for Cancer Research and our good partner, Dr. Brigitte Widemann. I've had the great privilege of working with Dr. Widemann for the last 20 plus years, and she immediately recognized what an opportunity this was to bring this international community of sarcoma patient advocates together in Washington, D.C. It has always been a core value of hers to engage patient advocates within the programs. The pediatric branch chief, she's a pediatric oncologist, and she has a research interest in neurofibromatosis and malignant peripheral nerve sheath tumors, and she has set up several special clinics specifically for subtype-specific sarcoma patients to come and be seen at the NCI. So she has been an incredible champion for this program. for us. And so if we could take a look at that video from Dr. Widemann.
Thank you so much, Denise, and welcome to everyone to the first sarcoma patient advocacy global network meeting in the United States. I would like to sincerely thank Denise Reinke, Mickey Geisler, and Catherine Schuster, who invited me about a year ago to help co-organize this conference. I've been very excited about this, and I hope you will see this will be a terrific meeting which will allow us to make progress working together. There were a number of hurdles we had to overcome, and not all plans worked out the way we had intended. Initially, we had hoped the meeting would be here, in part, on the NIH campus, and I had also hoped, obviously, to be there in person for the entire duration of the meeting. However, due to a medical issue that is unforeseen, I won't be able to be there, at least in person. In spirit, I will. The agenda is wonderful, and my wonderful colleagues from the NCI will be there in person. And we start off next with Dr. Doug Lowy, who will talk to you and give an overview of the NIH, the NCI, and how we can help advance research for rare tumors such as sarcomas. Thank you so much, Doug, for being available today and sharing your wisdom and commitment. And this will be followed by the Pediatric Oncology Branch Clinical Director, Dr. John Glod, who, as many others in the Pediatric Oncology Branch, has a deep commitment to sarcomas and will provide a few examples of how the Pediatric Oncology Branch and the NCI approach sarcoma research. I wish you a wonderful meeting and thank everyone for participation and exchange that will lead to better therapies. Thank you.
So I might just add to Dr. Wiedemann's introduction of Dr. Lowy. If we could have Dr. Lowy's slides, please. This is my first opportunity to meet Dr. Lowy, but it's not the first time I've encountered his influence on the patient advocacy community. He has worked within the NCI to form and work with the Research Advocacy Council of the NCI, and at SARC, when we were looking to find a way and a model for engaging patients in research of SARC, I used the model that was established at the NCI, and I often speak to and share this quote from Dr. Lowy of how he talks about how important research advocates are, that they play a vital role in shaping the NCI work. They challenge us and ensure that we never lose sight of what we are here to do, which is to improve patient outcomes by advancing cancer research. We can't do this without the unique perspectives research advocates bring. So it's truly a great pleasure to have you here today with the patient advocates. Thank you so much for being here.
Thank you. So in conclusion, Denise has essentially taken what I was going to say, but I mean, this is, and I also appreciate that this is a photograph of me from about 3 weeks ago. But let me just say that the real issue here to me is rare tumors. And what we try to do is essentially focus on them, not exclusively, but they are a major focus, whether it is pediatric cancers, as you'll hear from John Glod in a few minutes, or adult cancers. And we actually had a moonshot initiative called My Part that Dr. Widemann was the co-lead of that really was focused on rare cancers, rare adult cancers, and childhood cancers with an international flavor, so that people could enroll in this program, whether they were in the United States or elsewhere. It really has been a very successful program. Sarcoma is not just something that we think about, but my father died of sarcoma 30 years ago this year. So I'm very well aware of the therapeutic challenges that are faced by patients who have this disease. And I really applaud all of you for getting together now for more than 15 years to be advocates and partners in the research on this important issue. So first, I'd like to show you where we are, the Bethesdan Hotel on the left, and the NIH Clinical Center in the middle on the right, and there's the Children's Inn, where the children and the parents or other family members have a place to stay when they're not being treated. And the Naval Hospital that has more recently been named the Walter Reed Army Medical Center is located across the street. And we have two parts to the intramural research program. There is the Division of Cancer Epidemiology and Genetics, where population science is done, and then the Center for Cancer Research. And the Pediatric Oncology Branch and my lab are in CCR. And importantly, what's the mission of CCR? And it's to improve the lives of cancer patients by solving important, challenging, and neglected problems in cancer research and patient care. So you're not going to be tested on this organizational chart, but basically, the NCI is a big organization. And CCR and DCEG occupy a little more than 10% of the resources or the budget for the National Cancer Institute. And this repeats the mission, but really to create the medicines of tomorrow and doing high-risk, long-term, and it says daring, that's in the eyes of the beholder, basic and clinical research enabled by access to institutional resources. And I'll just tell you, in terms of my own research, my laboratory developed the technology that underlies the human papillomavirus vaccines, the 3 FDA-approved vaccines. And what we have been doing in the last few years is actually something that we do in other areas of cancer as well, which is dose de-escalation. So we have been trying to determine if you could actually get away with just one dose of the vaccine rather than the 2 or 3 doses that are currently recommended for the United States, depending on the age. So it's not just the medicines of tomorrow, but in addition, trying to think outside the box of, can you actually get away with less? So CCR is a key part of it is the clinical center at the NIH. And John will be talking with you more about that, because that's where the Pediatric Oncology Branch is located. And it's a comprehensive program. There are around 225 principal investigators in multiple laboratories, and it's actually divided between the Bethesda campus and the Frederick campus, which is about 40 miles north of here, and it's big. We have about 3,000 staff, but very importantly, almost half of the people on the staff are trainees, and we train a lot of people who go to many other places. And the people who can't find a job anyplace else, we keep them here at the NCI. No, I'm just kidding about that. The really outstanding people who stay here, and we're just so privileged to have so many outstanding people. And I think of the key aspects that we have are the freedom to pursue what we think are the most important problems, risk-taking, dare to ask provocative questions, and also this long-term time frame, because when it comes to extramural grants, most of them need to be completed or at least to have made a lot of advances in 5 years. But some problems just take a lot longer. And we, of course, have access to the clinical center. And it's the largest clinical research center in the world. Dr. Jay Bhattacharya started last week as the new NCI director, and on Wednesday, he was interested in seeing the clinical center, and the pediatric oncology branch was one of the places that he wanted to see, and really to see firsthand the challenges that we face, but in addition, the progress that we are making. The clinical center really is a research hospital. Everybody who's there is on a research protocol, and with clinical trials in general, people get the standard of care, or they get standard of care plus what we think is going to actually give them even more benefit, but we don't know. And just in case I forget to say it, we are completely dependent on our patients and their altruism, as well as wanting to have a greater possibility of getting better. But really, they are the people who are the engines of discovery, because we can do things in mice, in cells in the laboratory, but the way we find out that what we're doing either does work or doesn't work is through patients and clinical trials. And without patients, we would be nowhere. So the unique features of the CCR clinical trials are generally to focus on early phase trials. That's what the clinical center is set up to do. And it's shown on the left. We think that we're passionate, high quality care. People who come to the clinical center don't pay. It is free of charge. Anyone in the United States. And there's also travel and lodging support that's provided. And we also provide consultation. For example, and people don't need to be here in order to provide the consultation. We can do telemedicine, and not just within the United States, but even outside the United States. I got a letter from someone in Sweden whose child had an uncommon tumor, and he participated in this MyPart trial, and then had a consultation, ended up getting the recommendation to be on a different treatment from what was being recommended in Sweden, and has had a terrific clinical response. Now, of course, that doesn't always happen, but that's what we're here to do, to try to improve the outlook for patients. And so there's a lot of screening that takes place, and we have a lot of facilities for doing sophisticated analyses. And let me just talk about rare tumors, because for adults, each tumor type is rare, but those tumor types collectively account for about 1/4 of the deaths from cancer in the United States. So we're talking about around 125,000 people each year in the United States die from rare tumors. That's a lot of people. And then this, I did not put this slide together, but these are some of the areas where CCR has made progress. And then really kind of a timeline, because we are involved in research that leads to many FDA approvals. But of course, not everything that we do is successful. And as I say, it's really through the clinical trials process that we find out, do we have something that is a real advance, or do we have something that was great for mice, but not so great for people? And being able to do that and having the luxury of being able to go from the laboratory to the patient, and then we learn from the patients and come back to the laboratory. It really is an incredible opportunity that we have to try to improve the outlook for patients. And then finally, I just want to come back to training. A big part of what we do is to train people who then go out and are leaders in many other areas. And a high percentage of the people whom we train come from outside the United States. Some of them end up staying, but many of them go back to their home country. So it really is a privilege for me to be able to talk with you. And I wish you a terrific conference. I think you don't need my help for that. It sounds like you've been doing a great job for more than 15 years. So, and I think that John Glod is going to be talking next.
And finally, we welcome Dr. John Glod from he's the Pediatric Branch Clinical Director. He's part of the Center for Cancer Research, pediatric oncologist with interest in improving understanding of rare solid tumors in children and identifying therapeutics. And we're pleased to have you here with us today. Thank you.
Thanks, Dr. Lowy. Well, it's a great pleasure to be here. And Dr. Widemann sends her regrets. She's really was looking forward to this conference, and she really wanted to be here, but you're going to have to put up with me instead. So the picture they got of me was not as nice as the picture they got of Dr. Lowy, but I'm going to have to talk with the AV people and see if we can fix that. So let's see. So I'm going to talk about a couple of things. I wanted to give a little bit of introduction to the pediatric oncology branch, how we think about things, what we do, and then give a couple of examples of projects we worked on with sarcomas that kind of illustrate a few points that I think are really important in making progress in these really rare diseases. In pediatric oncology, all of our diseases are rare, and some of them are super rare. And the only way we could really make substantive progress in any of these diseases is with a team approach. And the team approach is investigators working with each other, and patients and patient advocates putting in their time, putting in their willingness to participate in trials, and the cooperation has to go not just in one country, but across international borders. And hopefully I can point out some examples of how we've been able to leverage those things to make some progress. So our goals in the pediatric oncology branch are to improve the survival and quality of life of kids and young adults with cancer and cancer predisposition syndromes. And this spans all the way from very basic biology to cutting edge first-in-human clinical trials to really understanding drugs that we already have and how to use them better. And the pediatric oncology branch is not giant, but we do span all the way from very basic science like that to running trials that are developed in our lab in the NCI. So these are a few examples that I'll go through. I won't go through them here because I think I have slides for most of them, but how we can use some of this cooperation and some working together to make advances in pediatric oncology. And the first example I wanted to bring up is something that's been amazingly successful, and I know a few people in this room have been to these clinics or know about this clinic, but the NIH GIST clinic and the wild type GIST clinic. And so this was the brainchild of Dr. Lee Hellman. Many of you may know Lee, he's there in the middle. And I think the first one was in 2011. And at that point, it was well known that there were gastrointestinal stromal tumors, a kind of GI sarcoma that is effectively treated with KIT inhibitors, was prevalent in adults. But many of the kids were not responding to KIT inhibitors, but we didn't really understand why. And by accumulating patients, young patients, kids and young adults with GIST tumors that did not have KIT mutations, Lee and some other researchers and at a number of different places began to understand that what was driving these tumors was mutations in succinate dehydrogenase, a different mutation. And so I think from the time in 2011 till the time now, we went from not understanding the biology of the disease to understanding better the molecular biology of the disease, figuring out that we could actually run trials specifically with these patients. Actually, there's a number of trials and a few treatments that look like they may be useful and successful in treating patients with succinate dehydrogenase deficient GIST. And this is all brought about by combinations of investigators from different institutions and even different countries coming to the NIH, sharing ideas, talking with patients, and beginning to understand the disease through that kind of collaboration. I next want to bring up the International Rhabdomyosarcoma Genomics Analysis Study, and this was headed by Jack Sheeran and Javed Khan in the Pediatric Oncology branch and the Genetics branch, the NCI. And it was a collaboration that spanned the UK and the Children's Oncology Group in the United States. And what was, I think, is the main take-home point of this study is even though rhabdomyosarcoma is a rare disease, there are even more rare subtypes of rhabdomyosarcoma. And the subtype that really kind of stuck out was MyoD1 mutant rhabdomyosarcoma. So you could see the Kaplan-Meier curve of survival in patients with MyoD1 wild-type rhabdomyosarcoma versus MyoD1 mutant rhabdomyosarcoma. You can see that the treatments that we're using don't work for people with MyoD1 mutant rhabdomyosarcoma. And so this is parsing out a tiny subgroup of patients with rhabdomyosarcoma that we were not helping. And maybe we can now that we understand there is that subgroup, we can develop effective therapies for those kids. Dr. Lowy mentioned this earlier. This was started by Dr. Widemann and Dr. Wedekind, Mary Frances Wedekind, it's the My Pediatric and Adult Rare Tumor Network. And the idea behind this was that can we have a broader reach and learn from every patient with a very rare tumor, or try to learn from every patient with a very rare tumor. And we would collect medical records on these patients, we would talk to the patients, we would collect biological samples, do genomic analysis, and begin to try to understand rarer subgroups of disease. And I think we learned a couple of things from this. This is just a depiction of the number of patients accumulated on the study with different kinds of tumors. And you could see chordoma and gastrointestinal stromal tumor at the top. And I think we understood, the things we learned from this study is that yes, we can remotely collect a lot of information about patients and it can be very useful. But what we really need is individual patients, groups, and physicians and researchers to champion the study of a particular disease to really make headway in that disease. And so as the infrastructure of this has grown out, other investigators from other institutions are taking on some of these other rare diseases. And there's Dr. Wedekind up there in the corner. And kind of related to and growing out of that is a US national initiative called the NCA Childhood Cancer Data Initiative. And this is partnering between the NCI and the Children's Oncology Group. And the Children's Oncology Group already had a project called Project Every Child. And the idea, again, being these diseases are rare enough that we can't waste a single minute and not learn from every single patient who enrolls on a COG study. Every single kid with cancer we have to learn from. And so the idea behind this is that can we take molecular samples and obtain molecular data from every kid enrolled on a COG study? And it's been very successful. Enrollment as of January of this year, it started with tumors of the CNS, has expanded to other disease groups, including soft tissue sarcoma. So as of January this year, over 1,000 kids with soft tissue sarcoma have been enrolled. And there's been some really interesting findings in this study. There's been diagnosis, and the patient sample is collected, the molecular analysis is performed, and then the results of that molecular analysis is returned to the patient and the treating physician so that they could use that to make treatment decisions. And so the diagnosis of these patients has been refined in about a third of these cases, and there's a targeted therapy available for about 15% of these kids. So I think we're just at the beginning of this. Looking at the raw data from this project is really interesting. There's features of small subgroups of diseases that I think we're really going to learn a lot about, and already I think it's impacting the care of patients. This is a study of gamma secretase inhibitor in desmoid tumors, and it was run by Dr. Alice Chen and Shivani Kumar. And Alice, I think, you're going to hear from later. But this was a study that was championed by the Desmoid Tumor Research Foundation. And without the cooperation of both the patient advocacy organization, interested researchers, and understanding the basic biology of the disease, this kind of success could not happen. And you could see just in the waterfall plot there in the eventual phase 3 study of this agent, there's tremendous success in treatment of desmoid tumor, a disease that previously did not have a particularly good systemic therapy. This is work also by Dr. Chen, and I took care of the pediatric patients on this study. Again, the point that this study kind of illustrates is sometimes pediatric oncologists and adult oncologists don't talk maybe as much as we should, but I think in some of these diseases that span the pediatric and adult age group, when we work together, we can make faster progress for kids and for adults with cancer. This is a study of a checkpoint inhibitor called atezolizumab for a very rare type of soft tissue sarcoma called alveolar soft part sarcoma. There were tremendous responses in about a quarter of these patients in a disease that didn't have a great treatment prior. You can see one of our patients, the CT at baseline, and then at 60 cycles, most of those pulmonary lesions are gone at this point. But a very important feature of this trial, from my perspective, is that we added pediatrics to the trial at the very beginning. So the old time sort of standard way of doing studies for new drugs is first you do the adult study, then you do the pediatric study. And that leads to about a lag time of about 7 years between an effective therapy getting from adults to kids, and that's too long. And so if we include kids at the beginning, we can get effective therapies to children faster. I'm going to talk about just a little piece of very interesting and amazing basic science research. This is in Dr. Rosie Kaplan's lab, and Sabina Kazakowska and Jessica Lake worked on this project. And so you've all heard about cell therapies, I think, at this point, and CAR cell therapies. What Dr. Kaplan is working on is taking another part of the immune system, the myeloid cells, and genetically engineering those cells to facilitate treatment of tumors. She has some extremely amazing preclinical data, and a clinical trial is in development. So hopefully we'll have that up and running in the next year. And this illustrates another component of what we can do at the clinical center. Take something from Rosie's benchtop to being able to deliver this therapy to first in human studies and hopefully to kids within maybe the next year or two. And then a talk like this could never be done without including Dr. Wiedemann's amazing work on plexiform neurofibromas. So this study, you heard Dr. Lowy talk about if you're outside the NIH intramural program in the United States, your time is measured in 5-year R01 periods. In the NIH intramural program, you can take a longer time to learn something. And this is work over probably 25 years from Dr. Widemann of trying to find a treatment for plexiform neurofibromas. And so the MEK inhibitor selumetinib has been very effective for that. You can see the waterfall plot. You can see selumetinib, the progression-free survival is dramatically improved compared to the natural history study. And a couple of the things that she did in her natural history study in the 25 years leading up to this study made this study possible. One is that she learned the natural history study of these lesions, plexiform neurofibromas, and she invented a way of actually imaging them so you could tell how big they were getting. The methodology for imaging these tumors was not particularly good when she first started. And so understanding the natural history, understanding the impact on the patient, and then having that information allowed the study to be done. And this selumetinib is now approved in, 50 countries at this point. So this was a research started at the NIH Clinical Center that's now having an impact worldwide. And then last, this is something that we need to work on a bit more, malignant peripheral nerve sheath tumor. I don't know, many of you may know about this tumor. This is another tumor, soft tissue sarcoma associated with neurofibromatosis type 1 that at this point we don't have good therapies for. But this study with Denise, Vandana, Akshantala, Aaron Kim, and Brigitte shows that we can do phase 2 trials for refractory MPNST, but that we need to continue to collaborate and work together to try to find better therapies for this. Once again, thanks very much for Denise, Michi, Catherine. You guys have been amazing in sort of helping me make my way onto to give the talk today in place of Brigitte. And also, I want to point out Terry Moore and Trish Whitcomb from the NCI, who really did a ton to try to organize this conference. And this is Brigitte's photography. She went down to see the cherry blossoms earlier this year. So I want to assure you that our weather is not always like this. And some of the pictures you see are not made up, but often the weather around here is very nice. Thank you.